Hello, and welcome to the Nursing Economics podcast series. This series provides extended content relating to articles published in the journal, such as interviews and roundtable discussions. Before we get started, we have a special offer for our listeners. You can save 50% off 1- and 2-year subscriptions to Nursing Economics. Simply visit nursingeconomics.net/offer to take advantage of this special discount. In this episode, Dr. Donna Nickitas, the Dean and a Professor of Nursing at Rutgers School of Nursing in Camden, New Jersey, and the editor of Nursing Economics, talks with Dr. Michelle Williams, the Dean of Faculty, and Dr. Stephanie Ferguson, a visiting fellow, both at the Harvard T.H. Chan School of Public Health in Boston, Massachusetts. Dr. Williams is an internationally renowned epidemiologist and public health scientist, an award-winning educator, and a widely recognized academic leader. Prior to becoming dean, she was professor and chair of the Department of Epidemiology at the Harvard T.H. Chan School of Public Health and program leader of the Population Health and Health Disparities Research Programs at Harvard's Clinical and Translational Sciences Center, Harvard Catalyst. Her background includes a distinguished career as professor of epidemiology at the University of Washington School of Public Health, co-director of the Center for Perinatal Studies at the Swedish Medical Center in Seattle, and an affiliate investigator at the Fred Hutchinson Cancer Research Center, also in Seattle. At the University of Washington, she developed and directed the Reproductive Pediatric and Perinatal Training Program. Her scientific work focuses on reproductive, perinatal, pediatric, and molecular epidemiology. She directed the multidisciplinary international research training program that prepares undergraduate and graduate students in global health, biostatistics, and epidemiology in South America, Southeast Asia, Africa, and Eastern Europe. Dr. Ferguson has worked in over 100 nations as a technical advisor, consultant, and facilitator for organizations such as the World Health Organization and the International Council of Nurses. Based in Geneva for over 10 years, she directed the International Council of Nurses Leadership for Change program and Burdett Global Nursing Leadership Institute, and she served as an International Council of Nurses consultant for nursing and health policy. Dr. Ferguson worked for more than 20 years at the World Health Organization headquarters and regional offices, where she developed strategic plans and initiatives to strengthen and evaluate global healthcare delivery systems, population health outcomes, and health professional education and leadership programs and services. She is the President and Chief Executive Officer of Stephanie L. Ferguson and Associates, LLC, a faculty member at Stanford University in the Bing Stanford in Washington program, and a visiting fellow at the Harvard T.H. Chan School of Public Health in Boston, Massachusetts. Today's episode presents a dynamic conversation with Drs. Williams, Ferguson, and Nickitas. Universal health coverage, health inequities, and worldwide poverty are current global healthcare concerns. Nurses are at the center of global public health, and collaboration between all disciplines, including nurse leaders, is paramount in battling global healthcare crises, such as the COVID-19 pandemic and the nursing shortage. Today's discussion focuses on ways to ensure nurses have the knowledge, skills, and ability to care for people at both the community-based level and around the world. We are pleased to present this important discussion with Drs. Williams, Ferguson, and Nickitas.
I'm Donna Nickitas. I'm the editor of Nursing Economics, and I'm delighted to invite our special guest today who are going to speak about nursing locally and globally and how these critical partnerships help sustain the health and the well-being of nurses and residents and citizens around the world. So let's begin with an introduction for each of our guests. Dr. Ferguson, would you be so kind to discuss a bit of your nursing background and how you began your work in global health?
Well, thank you, Dr. Nickitas. Thank you, Donna, for having us today. I am Dr. Stephanie Ferguson, and I've been working in global health for many years now. I started the journey when I was appointed the Deputy Secretary General of the Global Network for the World Health Organization for Nursing and Midwifery in the world. At that point, the Secretary General was Dr. Rita Carty, which many people know. She was also the dean of George Mason University, and I was the chair of the PhD program at George Mason in health administration, health policy, health ethics. We were a WHO collaborating center. And simultaneously, I worked for Dr. Sir George Aline, also from Jamaica. And he was the head of PAHO, the Pan American Health Organization. And so he appointed me to also represent him at the World Health Organization in the office of the secretary and the director general and the head of workforce division. So I've been in the game a long time. I have worked for the International Council of Nursing, ICN, for more than 10 years of my life. To be specific, started out in 2002, and that journey went until 2015. I was the head of the Leadership for Change program, which we had that in collaboration with the World Health Organization in more than 80 countries around the world. And then simultaneously, too, I worked for the World Health Organization. And many people know me because I'm one of the people who created several of the strategic directions for nursing and midwifery, both at the headquarters, also at the Eastern Mediterranean region, and also at the Pan American Health Organization region. And life goes on. I mean, here I am now. I'm a visiting fellow at Harvard University, faculty at Stanford, and I'm also the president and CEO of Stephanie Ferguson and Associates, which is a global health consulting firm. I've been in the game a long time, Donna.
Excellent. Well, thank you so much for that enriching background. Let's move next to Dr. Williams. Would you be so kind to share your background in public health and how you began your work in global health as well?
Thank you. First, let me thank you, Dean Nickitas, Donna, if I may, for inviting us to this conversation. I'm Michelle Williams, and I am Dean of the Faculty at the Harvard Chan School of Public Health. I am an epidemiologist by training, and I practiced as a faculty member for 20 years at the University of Washington, where I led a research laboratory embedded in a large hospital called Swedish Medical Center, where I developed a research program and an education program embedded in perinatal medicine. So I'm a maternal and child health investigator. While at the University of Washington, I developed and created capacity building programs primarily focused on serving and supporting the development of underrepresented minority students to be engaged in global health activities. Capacity building with a focus of closing the disparity gap and the access gap for educational opportunities in public health and global health has always been a passion of mine, largely because of my immigrant background. I'm from the Caribbean, but also because if we're going to make a difference in public health, we have to have a diverse, capable, and inclusive environment where professionals across all the spectrum, nurses, clinicians, engineers, you name it, all disciplines are represented and engaged in supporting global population health. And nurses are at the center of this, by the way. After 20 years at the University of Washington, I returned to Harvard, where I studied for my degrees and became chair of epidemiology. And there I had an opportunity to really learn about academic leadership, but also to imagine and create new programs. I've been dean of the school for 4.5 years. And as dean of the School of Public Health at Harvard, I think it is a critically important platform whereby we develop and model how we optimize and bring capacity, tools, agency, and leadership skills to the workforce that's at the center of global health. And I'm really delighted to be here in this conversation with you.
And we're delighted to have you both. So let's move on then. I am sure that our listeners would also like to know how you came to know one another and what keeps you both committed to addressing universal health coverage, health inequities, and certainly worldwide poverty. So let's begin with Stephanie, and then we'll move on to Michelle. Go ahead.
Well, Michelle and I are elected members of the National Academy of Medicine and the National Academy of Science, Engineering, and Medicine. And so we are very much sought out researchers and speakers. We were invited to be on a panel together with the White House, with the White House Fellows Program Annual Leadership Conference believe it or not, along with Rear Admiral Sylvia Trent Adams, which many people know. And the three of us were on the same panel discussing global health security, discussing our work in HIV and AIDS and Ebola, and in my own background with the first SARS infection that we had back in the early 2000s, 2003 era. And then with everything from Middle Eastern respiratory syndrome and H1N1 and H1N9 and H1N3 for people who don't understand what that means, pig flu, bird flu, every kind of flu that you can imagine that is out there. And so that's how we met. And so we've been at the forefront of serving on many committees, both of us. I was very active in one of the authors of the Global Health and the Future of the USA consensus study with the National Academy of Medicine. So I was talking about some of the results from all of that. And so here we are. We've been at those high-powered tables around the world together. And Michelle invited me to, be a part of Harvard. And it's just been a fantastic opportunity.
Donna, you know, because you're a dean, that your to-do list is always longer than what you can actually accomplish. But there are moments in time when the penny drops and that last piece of the puzzle just falls into place. For me, I had been, pardon the pun, but I'd been nursing this idea of engaging in a more intentional way, nursing and nursing leadership in global health, in public health, and in public health and global health leadership for 20 years. And the moment I met Stephanie on that panel with former Admiral Sylvia Trent Adams and with the dean who hired me, gave me my first academic job, Gil Oman, yes, I knew that the nursing aspiration that I had could finally be fulfilled if I could grab a hold of Dr. Stephanie Ferguson and never let go. That meeting was really important to me because we were talking about pandemic preparedness and response, looking back at the Ebola outbreak of 2012, 2014. And that was pivotally important because after that meeting, we started to talk, we started to plot and plan how we could really energize an advocacy and a capacity building program that would allow us to have nurses be at the nexus of global health security, universal health coverage, and accomplishing the aspiration of sustainable development goals. I had no idea that the year after we met, we would be talking about celebrating the year of nursing and nursing leadership. Yeah. So I'm just going to say it was a chance meeting that I am always going to remember. And I want to thank you for asking that question because it was, for me, the skies opened where I could start to see how collaboration could help us continue to elevate, support, and enable nurses in global health leadership.
One thing that I hear from both of you is this nexus of public health and nursing, but also the appreciation of interprofessional education and practice, that it takes multitudes of understanding of disciplines and how you both, one from nursing, one from public health in particular, come together and align. And why that's important, because it's going to go to my next question, because both of you have this unique perspective within your own disciplines, a shared perspective in your commitment to global health. So here's the question. What is the global health gap defined by WHO, including the Nursing World Report, and how does that commitment impact both of you, given your unique perspectives? And I have to say, Dr. Williams, you are unique because there's not many individuals who come from the side of public health who has the real appreciation of nursing, because our origins, certainly coming out of New York in the early 20th century, were in public health.
Yeah.
So you were talking the connection of looking globally at universal health coverage health inequities, poverty, and yet here it is, the World Health Organization coming forward wanting to include nursing in addressing this gap in this world report. So how do we inform nursing about understanding that it's no longer local, it is global, obviously from the current pandemic we're experiencing worldwide. So can you connect those dots for us and give us your own insight?
Stephanie.
Okay, listen, this is the thing. First of all, we commend the World Health Organization and Dr. Tedros for having the foresight to designate way before the pandemic 2020 as the year of the nurse and the midwife. And simultaneously, they also established the State of the World's Nursing Report. And so I would recommend anybody that's listening to us, please read the report. The new report, it will be coming out. We are already working on the new strategic directions for nursing and midwifery, which also will be coming out this year. And what we learned from that report is we cannot do what we need to do now for the world if we don't have enough nurses to care for all of the people of the world. We know we're going to be down about 6 million people prior to the pandemic. But now we know nurses are dying, nurses are sick. We also know we don't have the right nurses at the right place at the right time, being able to care for the people. Let's look at the vaccine campaigns now. And, we clearly don't have enough health workforce, but we definitely don't have enough nurses to be able to work in an emergency situation and then go back out to the community level and do what needs to be done with not only infectious diseases, but also non-communicable diseases. And so what that report talks about is how we need to make sure that we ensure nurses have the knowledge, skills, and ability to do what they need to do at all levels of the workforce that they are in order to care for the people of the world. And that is both at the community-based level, at the public health sector, that is at the global health security level, where we have to work with these infectious diseases that become epidemics, then go to pandemics. And we have to be prepared for these disasters. But we also have got to care for people where they are, which is in their communities. We've got to turn the corner right now. We talk about this all the time, but we still have a medical model. We still have a model that is very acute care oriented, hospital based. And so one of the things that Michelle and I have a passion for is we've got to get back to where we need to be. And that's in the public square as leaders in nursing, to be able to articulate what we need, but also to work with our colleagues to make sure that we can practice, do our research, and change policies according to the scope of our practice. And what I mean by that, to the extent of our knowledge, our education, our training, and our regulatory processes. So that's what we mean by that. Let us get out there and do what we need to do with the partners that we work with all the time. Yeah. All my life, I've worked with epidemiologists like Michelle. If you don't work with everybody that's in the health sector and outside of the health sector, you see what is happening now in our own nation, in the United States of America. We are not going to turn the curve on this pandemic because we don't have the right people at the right places at the right time, making the right decisions. So I turn it back to you, Don.
Yeah. Let me just add to that, because that's a beautiful response. And I just want to put an accent on something. Health and wellness, 80 to 90% of the drivers of health and wellness at a population level is determined outside of the actual healthcare delivery system. It is upstream in places where we live, work, learn, and play. The issues of housing inequality, the issues of substance abuse, behavioral and mental health, in gainful living wages. These are public health issues that live outside of the direct healthcare system. Nurses have always played a role in helping to mitigate and manage population health by helping to change the levers on social determinants of health. In school nursing, for example.
Yes.
And one of the things we've always done is expand the mandate and responsibility of nurses, but never really fully provide them with the tools, especially now with technology being integrated in an aggressive way, analytics for decision science, all the tools needed for population health management that helps us understand public health initiatives as well as primary healthcare initiatives. Primary healthcare and care in general is changing. We're seeing more retail health clinics set up. We're seeing more urgent care models. And who are the people who have the responsibility for executing on the protocol for care delivery? Nurses. But they've not been empowered, enabled, and supported to take the leadership role in designing these systems. Mm-hmm. And we want to change that because that has to happen if we're going to achieve the aspirations of universal health coverage, closing the gap in health equity, and really reaping the returns on the investments we make in the public health, population health arena. Nurses are critical and they have to be enabled and empowered to lead, not just in clinical settings, but also in the policy arena and in the local and regional public health governance arena.
Well, I think the next question might get to that.
Yes.
Let me ask this to both of you. How does a nurse scientist and an epidemiologist join forces to examine the issues confronting the nation's public health infrastructure to strategize a global health response?
Do you want me to go first?
Go first, my friend.
So here's the thing, and I'm glad you brought this up, because if you're really going to be innovative and you're going to manage populations, as a nurse, you have got to understand epidemiological science. You've got to be able to work with epidemiologists to really look at the prevalence, the rate of infection, and to calculate what needs to be done, how many people need to do that in order to make a difference and drive outcomes so that we can see a change in health behavior. And so, Donna, there's very few nurses that are able to articulate that and do that without being with a scientist who's an epidemiologist. And the co-creation, if you will, of innovations in public health and health in general, both illness and wellness modalities of care, where we need to turn the corner with everything related to non-communicable diseases, as well as infectious diseases. So I'd like to think that many of my colleagues who are nurse scientists like myself, whether you're a public health practitioner like myself or not, works on a daily basis with epidemiologists. But if you need to do what we need to do now in universal health care and global health security, you have to work with epidemiologists. They must be on your research teams. They have to be in your practice. They have to be in academia with you. Otherwise, you will not develop curricula or any scientific methodologies that will be useful and also show results. So that's one reason. I've always worked with epidemiologists and my whole career. So working with Michelle has just been a joy because both of us have a passion and a background with perinatal, neonatal. Many people know I'm a perinatal, neonatal clinical nurse specialist. We have a passion for women and children, women in general, who are in the workplace, in the workforce, and making sure women are at the right place, also at the right time leading. So being with an epidemiologist like Dr. Williams is just a dream come true.
I will say that one of the really important things, especially in academics, both in public health and in nursing, and I really believe this, is that we are equal partners, the practitioner and the researcher. And to the extent that we can really weight the value and appreciate and support both the discovery and methodology academic in our disciplines, as well as the practitioner in our disciplines, we have a feed forward and a feedback loop where we're constantly creating new knowledge and implementing those new knowledge into practice and policy that brings us to where each of us wants to be, and that is to have a positive impact in creating value, in improving health, and closing disparities on scale. And for me, that passion is to break down the town and gown divide that exists between the scholar and the practitioner. In the health space, we should be in lock step together. And I think the nursing community and the public health community can illustrate that and carry this forward in ways that we have done in incremental steps in the past. But COVID, Ebola, climate change, AMR, health disparities, all create a sense of urgency for us to do this in partnership immediately.
Critical. Yeah, very important that we understand breaking down those barriers between academia and practice. And I think we are making strides. Certainly, we're beginning to understand on the scientific side that we need our colleagues at the bedside and in the community to be able to take evidence-based practice and implement it in ways that are feasible and reasonable in that regard. I'm going to move back a moment because it's really important that we focus on the COVID-19 pandemic. And what I want to say is that it's been a real public health disruptor like no other in the world that we've experienced. The systematic disruption it has created in testing, tracing, treatment, dissemination, and administration of vaccines, including PPE, has impacted high, mid, and low resource countries. And yet no country has been unable to escape the horrific wave across its healthcare infrastructure. Stephanie and Michelle, why is that? Where did we get lost? We have such historic trends and understandings, and we were pretty successful given Ebola. But what happened here with COVID-19? Go ahead, Steph.
Well, here's the thing. Many people know that I started my career early on after my master's degree from the Medical College of Virginia, Virginia Commonwealth University School of Nursing and Medicine. And I went into public health. I was at the highest levels in the Commonwealth of Virginia in the Virginia Department of Health, doing newborn screening, sickle cell disease, hemoglobinopathies, the science behind the newborn screening methodologies is one, and women and children. I say that to say that we had a strong public health infrastructure. And that was back in the late 80s, early 90s. And then all of a sudden, we took away all the money, decimated public health infrastructures in all of the state levels in the United States of America, and not just in the USA, but all around the world. That money was taken out of the government funding for everything we need done now, which is from testing all the way to the mitigation processes of testing and services and isolation and retesting and care for people post-infection. And Donna, all of that is gone. And so we're starting from ground zero in many cases. You know, even in my backwoods of Virginia, where I live at the local health department, and I'm going to say their name, in Lynchburg, Virginia, I've spent a lot of my life helping them out as a nurse with some of my nursing and public health students at the University of Lynchburg, going out and helping them in the field, because at any given time, they might only have 6 nurses for the entire population of this part of Central Virginia. And so this is what we're up against. We don't have enough money. We don't have the resources, and we don't have the people. And so I always say to people, when you don't have people, processes, and products, testing, and all the different ways of doing your campaigns and your messaging, you're not going to do well with an infectious outbreak like COVID. So the United States of America has been harmonized now with every other low and middle income country and also high income country in the world. Welcome to the world on a level playing field, where many people are not ready. They don't have the infrastructure for what we need to do for public health. And so, Donna, that's why global health security is so important. You have to have a separate entity in your highest levels of government, at your local levels, at your provincial levels, however your structure is, so you can deal with a situation like this. This is beyond FEMA. FEMA in our country is very good for emergencies when there's a disaster of natural occurrences. Not saying that COVID is not naturally occurring, but what I am saying is when it's a disease, it's a different way of business, and health is business. And so I'll stop with that and let Michelle add on. But we don't have the money and resources for public health. It is a shame.
I'm going to add on a couple of points. One is on the infrastructure side. We have known for quite some time that our informatics system for doing surveillance and tracking, which is part of the remit of the Centers for Disease Control and the WHO, has been fragmented and has not been upgraded, invested in, and improved upon, even though there's massive new technologies available. So we've not invested in our infrastructure for basic core functions like informatics control, data surveillance, data processing, and analysis. And we have suffered greatly in this particular COVID-19 pandemic as a result. Communications. We have not had clear, thoughtful, evidence-based, science-driven communications to our populations across this expansive country, but globally as well. And you can't work your way out of a crisis, be it a climate change crisis or global pandemic that we're living through, or the economic crisis that's impacting our most vulnerable people, if you don't have clear, competent, consistent communications where leaders are also leading by example. And so I worry about the fact that we have lost our capacity to communicate with authority what a social contract could look like, what each and every citizen would have to engage in doing to bend the curve of a pandemic or to participate in an equitable and just distribution of a vaccine, as an example. So just adding to what Stephanie said, the workforce has been under-supported and under-invested with tools to do their work. The communications has been fragmented, and states and local levels have been left to manage massive resource-intensive operations like a vaccination program without having the financial or the workforce surge capacity to do the work while they're dealing with a surge of cases. So we have to better manage our resources, our human capital, and train them and grow them and support them. But we also have to reevaluate our engagement in the global governance of public health by rejoining the WHO. This would be the worst time to retreat from global governance in managing a global pandemic. And then more locally, we have to look at where we are failing by not supporting and enabling the federal government's role in state and local guidance and leadership in operationalizing public health practices like a vaccination program.
What I hear you both say is we have to take the politics out of the pandemics, bring the science and the technology along with the information. And so here's my next question to both of you. How do we get nurses to the policy table to transition the conversation towards innovation and design nurse models of care that include science and evidence-based practice, that align with humility, cultural diversity, gender neutral, and anti-racist sentiments?
Yeah.
Mm-hmm. I'm sorry, it's a big order. And I know that both of you, I trust that you can answer this question for me.
No, Donna, thank you for that. And I'm going to start, and then I'm hoping that Stephanie can really add. I'm going to give a high-level response to this.
Please make it provocative.
Because what you have just described is really the global public health agenda. It is, how do we address all of the challenges to population health and equity? These are challenges that we know we have to address because not addressing them has brought our nation to its knees. Without public health, without addressing health inequalities, we are vulnerable to a repeat of an epidemic, a pandemic, bringing an entire nation and an entire global economy to its knees. We knew that burnout is an issue in the health workforce before COVID. We knew that we had underinvestment and underprepared for pandemics and responding to pandemics. We have an opportunity now to look at where we have underperformed and to make real differences in supporting our population, our national security, our global health security. And I believe nursing health leadership in the population space and in the primary care space and in global health in general is an important way forward. And so we want to be very intentional and very vocal in advocating for nursing leadership to be at the table for regional, local, national, and global health governance. I think there is a voice here that has been missing, that is both humanist as well as operationally talented and gifted. And that voice at the table has to be empowered and enabled to really exercise that leadership voice. And so I believe in training, empowering, and enabling nurses to play an even bigger role in global health security by intentionally bringing them forward in a program that we're developing at the Harvard School of Public Health. And we want to do globally with all important thought partners, with academic nursing programs, with global governance leadership programs like the World Bank, like the IMF, like the Africa CDC. We believe that nursing should lead the next iteration of global health security because of where they sit in the primary healthcare and the population health space.
Yeah. Go ahead, Steph. You want to respond?
So I totally agree with everything that Michelle has said. And I think that the State of the World Nursing Report hit it on the head with the research to show that nursing is not where we need to be. A good start would be for countries to make sure that they appoint nurses at every level of every department, initiative, research study, politically appointed position within the government now. We need that now. We don't have chief nurses and chief midwifery officers around the globe like we should. Only 53% of all the countries in the world have that level of position. And when we look at that level of position, take that down at a deeper dive, only 71% of them have any type of nursing leadership plan, leadership program in general. And so when you look at that data and you think about the fact that we don't have the person in the place, and then even then, if there's another person that might be in the place, we don't have an agenda. And even then, if you think about it, we just don't have them at the table making the decisions that need to be done. And I think Michelle articulated it very well, what needs to be done and why they need to be at the table and what they bring to the table. And so this is a time to ask for that now, including in our own country, in the United States of America. You know, I haven't seen enough nurses yet be appointed to any level with the Biden-Harris administration yet. And so it's upon all of us to ask that question and to beg, you know, the question, where's nursing? Yeah. Where's nursing at the table?
Yeah, and it has to be at the leadership table.
Yes.
And nurses, you know, for a lot of years, I kept hearing about task shifting, and I would see the task getting shifted. And that's not the right model. The right model would be to have those health professionals who are in the communities, who are doing the everyday operational implementation of policy for clinical care and population health management, to enable and empower them to, first of all, have a voice in interpreting the evidence, designing the policy, and then also implementing on that policy. And of all of the professions that come together in the public health, healthcare, population health space, the group of professionals who are at that nexus of translating policy to practice are nurses and public health leaders. Mm-hmm. And we really need to be more intentional. We need to understand that the mandate for nurses need to be matched with the tools, the advocacy and leadership voice, and the technical skills necessary to succeed at the job. And if we do this, we will have a stronger, more resilient global public health system.
Yes.
Excellent. So you probably already answered this a bit, but let me just re-ask it anyway. And that is, what would you recommend for effective strategies to close the global health gap? Are there specific recommendations that you could provide for our leaders and our listeners where you sit? In other words, you're my advisors right now, and I'm asking you at the end of the day, you know, what are the 1, 2, or 3 takeaways that would position nurses wherever they are, whether they're in the classroom, the boardroom, or the community. What can you advise them to say, here I am now in this moment of time, and I'm asking you to say, if you want to think about engaging and getting to the table to have your voices amplified and your advocacy met, here's what I think you need to do.
I'm going to start with one really important thing, because this is the moment in time. We must collectively insist that our government re-engages with the World Health Organization. We have to have a strong global governance for global public health security. And our community of nurses and public health people should lift up our voices and first and foremost advocate for a strengthening of our World Health Organization, more locally, our Centers for Disease Control Prevention, and to re-engage and reaffirm our commitment to science and evidence in our FDA. I think starting at the top of these institutions and holding them accountable and rebuilding trust in these institutions are going to be important. The other thing we have to do below that level is to make sure we are adequately funding these organizations to meet the mandate that they have, that is global, national, and local. That's where I would start.
I totally agree with Michelle. One of the things I'm going to put Michelle on the spot, but she wrote a fabulous article in The Lancet last week. It came out, and it really talked about what the Biden-Harris administration should focus on from a global health perspective. And so I would encourage all nurses who are listening to us right now and other health professionals to read that article. And Michelle can talk about that better because she wrote it, along with Donna Shalala, who's another great advocate for us. Many people know I worked with Donna when I was a White House fellow. We have got to get we got to get back at the table. Let's just say this. It's difficult for you as a nurse to get at a table when your own country is not at the table. Does that make sense? And your own country's house is not right at this point. And I think Michelle hit that on the nail. The other thing for us in nursing is, do a deep reflection and quickly. Are you teaching what you need to be teaching now across the board, from baccalaureate level all the way to the doctoral level, what we need to do to be in this space of global health and global health security? And I would argue that some people are not. And so this is the time to do that. Are you advocating for the infrastructure for public health to be put back in action in your local area, at your state level, in your country, in the United States, I'm going to use, or wherever you are listening to us in the world? Do you have enough nurses at the right place at the right time now? Are you advocating for the resources that nurses need in order to teach, to get the graduates out to be in the field, and then to be able to go to the next level of advocacy so that we are positioned in the right places to have our voice heard? But more importantly, once our voice is heard, that we are able to collaborate with others to show outcomes. We have to show outcomes. We have to show effectiveness with all of this. I loved it when Her Royal Highness Princess Muna, she was given the highest award recently last year at the World Health Assembly with Dr. Tedros, who's the Director General, for her leadership around the world. Many people know her from the Eastern Mediterranean region of the world. She's a patron for nursing for WHO in that region. She's the mother of the King of Jordan. She's a champion for nursing. But what I liked that she said recently was, enough already with the hero talk and the hand clapping and all of that. Nurses need to be at those tables, but also nurses need the resources so that they can be successful. And our country needs the resources now so we can be successful with nurses within that process at those tables. So I think, Michelle hit that out of the park. We've got to get back to the basics. We became too nationalized, and even then our structures nationally were weak. You can't be by yourself when you're dealing with global pandemics and with global issues. Yeah. We live in a globalized world.
Thank you for that reminder. Dr. Williams, would you be so kind to share the title of your Lancet article for our listeners?
Yes, I would be delighted to do that. And thank you, Stephanie, for bringing that forward in our conversation. I want to share the title, and then I want to share the authors, because in sharing the list of authors, you will see our commitment to really working across disciplines. And that's really important. We have to demonstrate and illustrate how important it is to collaborate. The title is A Global Health Action Agenda for the Biden Administration. And it was published January 2nd in The Lancet, volume 397. I will say it was a real privilege to work with Professor Larry Gostin of Georgetown University, a professor of law, to work with Donna Shalala, Margaret Hamburg, the former FDA commissioner under the Barack Obama administration, Barry Bloom, who preceded me by 2 deans at the Harvard Chan School of Public Health, an important scientist, Jeffrey Copeland of Emory University and a former CDC. We're using our voices. Other co-author included Barbara Reimer. And so we really got together, put our heads together, and tried to come up with a bit of a roadmap and an action plan for our nation's re-engagement in global health governance. And I believe that we can get there, but we have to recognize the scope and scale of the challenges ahead of us. And we have to commit to reinvesting and rebuilding our workforce and our systems and infrastructure. And I believe we can really get there. We spend the money. It's not a function of resources being put in. They just have to be managed and coordinated in a competent way. And I believe we can do that, and nurses can lead the way. You know, we have a ministerial leadership program at Harvard University, which was designed by Julio Frank, the former Minister of Health of Mexico and former Dean of Harvard School of Public Health. That program is an excellent program because it sought to break down barriers between ministers of finance and ministers of health and ministers of education. And the kind of thinking about bringing these ministers together across sectors is prescient because we are interdependent. A minister of finance is, whether he knows it or she knows it or not, is engaged in global health governance. A minister of education is engaged in public health, global health education and governance, whether they know it or not. And if any one of them fails, our economies get brought down to our knees. And so I really want to put an emphasis on leadership and governance and management that brings together what you basically said, Donna, interprofessional learning and practice.
Well, I'm glad you got to the finance piece because I wouldn't let you both get away with not having to talk about the economics of healthcare. And certainly for our journal, our readers are always looking at the bottom line. So here's the last question for both of you. What's the business proposition for nurses as it relates to healthcare quality, cost, and delivery? What is the role of nurse leaders in making clear their business case in caring through policy, regulations, standards, workforce, and practice?
That's a great question. Stephanie, we started to write about that in our editorial. I'm going to ask you to take the lead on that.
Yeah. Well, in simple words, and I say this all the time, many people have heard me say this: no nurses, no health system, no country.
Say that again.
No nurses, no health system, no country.
Mm-hmm.
And we have to remember that. As President Ned Kennedy of the ICN says all the time, we're 80% of the world's workforce. So you think about that. And we are the majority health professional. One of the things, Donna, that Michelle and I really appreciated was being with you when you had a special edition on nursing economics that focused on what would the world be like without a nurse or without nursing. And so I think people need to really reflect on that, to think about that, to think about the business of health, to think about what it takes to be able to be effective now in all aspects of health and healthcare delivery, health strengthening, universal health coverage, securing a nation, national security issues in global health and global security. That's my short answer to that. We're at the forefront. We need to be at that forefront because we are key in making a difference and making sure that the health of a nation goes forward to care for all the people in our world. So I'll turn it back to Michelle.
I'd love that response. I think the business case, we're living it and we're seeing it. Our economy came to a standstill when our healthcare system was crushed. And that system rests on the back of a cohort of nurses and nursing leaders that the world is just beginning to appreciate fully the major roles they play. I'll also say, taking it up to a global level, the WHO's annual budget is $5.8 billion. That sounds like a big number. That is a pittance compared to the scope of the mandate of that organization and the return on investments all of the partner nation states accrue if and when we have a well-functioning global health security agenda executed. So at the very high global macro level, down to the community level, the returns on investments for investing and supporting and enabling our healthcare workforce that is still largely a women-dominated, 90% of the workforce is still women, is very much at the pinnacle of an entire health and economic security agenda for our nation and the globe. Mm-hmm. We can't overstate the economic, national security, and health value of the role nurses and the nursing profession plays nationally and globally.
I agree totally. And I just want to go back to it. We're still the majority, nurses are, of the entire professional workforce in our world. And I can't say it enough. I mean, we're more than what people are saying, in my opinion. And I just want to go back to Annette Kennedy's response about the 80% of all the care that's hands-on care, Donna.
Right.
It is by the nurse. And so Michelle knocked that out of the park. There's a gender issue going on with this. And I think many times we're not at the tables or invited to the table because we're majority female executive leaders and healthcare professionals and people doing the hands-on.
I thank you for, first, your honesty, your transparency, and your level of being able to explicate the importance of nursing. In the November-December issue, I had the pleasure of co-authoring the editorial with Stephanie, and it was a seat at the table, the global nurse critical imperative. And there's a quote that we start our editorial with, and I just want to share with you, get your response, and then we can end. And we say, from the front line of care to classrooms, communities, and boardrooms, nurses have come home to reflect how they were the first and remain the only unequivocal, effective defense against severe acute respiratory syndrome, COVID virus 2. I think both of you have so illustrated that through our conversation today about the full recognition, the appreciation, and contributions of the nursing workforce, locally, nationally, and globally. And so I'm going to give you both the last words before we end this podcast. So, Michelle, do you want to go first?
Yes, let me end on a personal note. Both of my sisters are nurses. They are my heroes. They bring compassion and skill and dedication to their work, and I have always admired them from my perch as an academic. This mission and purpose of mine is one that I have held close to my professional and personal bucket list for a lot of years. And I want to publicly acknowledge the fearless leadership and commitment of nurses everywhere. And I want to acknowledge you, Donna, for your leadership and your bringing forward the voices of so many, and you're creating and building capacity in everything that you do. And I also want to end by thanking my friend Stephanie Ferguson, who is a critical, fundamentally important person in helping me personally go from aspiration to operations. And we are a dynamic duo, and I'm just so grateful that we have an opportunity to build, to plan, and to create a capacity building opportunity for nurses and nursing leaders.
Yes. And so, well, thank you for that, Michelle. And I echo everything that she has said about you, Donna. I feel like if we don't invest in nursing now, we are not going to achieve the Sustainable Development Goals. We are not going to achieve universal health coverage in our world. And we're not going to secure our nations from a global health security perspective. We just finished up by the end of May, more or less, of this year, the Nursing Now campaign, which was funded by the Burdett Trust in collaboration with the ICN and the World Health Organization. All of our colleagues that we love and know worked hard on that State of the World Nursing Report. And so I would encourage people to be on the outlook for the new WHO strategic directions for nursing and midwifery, which will come out in the world this year, and really take those strategic directions and go to your ministers of health, to your prime ministers, to the presidents of our countries, and say, look, we need to get this done. We need to secure the workforce. We need to create jobs. We need to enhance our leadership capacity, our educational curriculum, strengthen our regulatory processes for the way we regulate nurses and midwives, and also care for public safety of people with those regulations. And we need to maximize that right now and do that right now. We need to invest in nursing right now. And so that's what I'd like to end on. And I'd like to thank you and the journal Nursing Economics for focusing on that. It is about the money. It is about health. Health is business. And so without that level of the workforce, the nursing workforce at those tables, making those decisions, making those policy recommendations, implementing and evaluating those services, we are not going to turn the curve to ensure a healthy planet. And so that's my final comment.
Thank you both for this informative conversation, but most importantly, thank you for your commitment to ensure that we make the call to action for nurses clear, concise, and forthright. What a privilege that I've had this chance to speak with both of you, and I look forward to our continued work in the future. Thank you.
Thank you.
The Nursing Economics podcast series is owned and produced by Genetti Publications, Incorporated. All rights reserved. No portion of this podcast may be used without written permission. Dr. Michelle Williams is the Dean of Faculty at the Harvard T.H. Chan School of Public Health and the T&G Angelopoulos Professor of Public Health and International Development at the Harvard School of Public Health and Harvard Kennedy School. Dr. Stephanie Ferguson is a visiting fellow at Harvard T.H. Chan School of Public Health in Boston, Massachusetts. Dr. Donna Nickitas is Dean and Professor at the Rutgers School of Nursing in Camden, New Jersey, and the editor of Nursing Economics. For archived episodes of this podcast and to learn more about nursing economics, visit the journal's website at nursingeconomics.net. You can also subscribe to the Nursing Economics podcast on Apple Podcasts, Google Podcasts, Spotify, Stitcher, TuneIn Radio, our hosting site Spreaker, and everywhere podcasts are found. And remember, as a listener, you can save 50% off 1- and 2-year subscriptions to Nursing Economics. Simply visit nursingeconomics.net/offer to take advantage of this special discount.